Atrial fibrillation, AF, ECG. Atrial activity. AF is characterized in ECG by 1. Rapid and irregular, 400 to 600 per minute, atrial fibrillatory waves, F waves, replacing the clearly defined P waves of sinus rhythm, generally best seen in V1 and inferior leads, less often in lead 1 and AVL. 2. Undulating baseline, alternating between recognizable atrial activity and a nearly flat line. F waves. F waves vary in amplitude, may be fine, amplitude less than 0.5 mm, coarse, 0.5 mm or more, or inapparent, which is most likely to occur in permanent AF. F waves vary in morphology and cycle length, reflecting the multiple potential wavelets of atrial activation that may be present at the same time at different locations. AF may be classified into fine, with minute or unseen F waves, or coarse, with large well-seen F waves. Correlation of F waves with disease. F wave amplitude may correlate with the duration of AF, the longer the duration the smaller the amplitude. But not with the size of the atria. Or the type of heart disease. Atrial contractions. Ineffective irregular atrial twitches replace the normal atrial contractions that occur in sinus rhythm, due to the very rapid firing rate. Ineffective contraction causes stagnation of blood and invites atrial thrombi. Differential diagnosis. Other rhythms with irregular RR intervals include 1. Atrial flutter or atrial tachycardia with varying AV block. 2. Multifocal atrial tachycardia. 3. Frequent premature atrial contractions. 4. Wandering atrial pacemaker. 5. Artifacts, for example, muscle tremors in Parkinsonism, can simulate F waves. Apart from artifacts, distinct P waves are generally present during these arrhythmias. Fibrillation or flutter. The distinction between AF and atrial flutter can be confusing in the following conditions. Patients with rheumatic mitral stenosis, who often have large amplitude fibrillatory, F, waves in V1 and V2, F waves, however, have varying cycle lengths and morphologies. Patients who demonstrate a transition between AF and atrial flutter, thus, AF may organize to flutter, and flutter may degenerate into AF. Intracardiac recordings. A waves in intracardiac recordings may show variability in morphology, amplitude and cycle length, with or without an isoelectric baseline in between. A waves may rarely be absent. This schematic shows variation in amplitude, configuration, and cycle length among A waves in AF. How to define the source of AF? The following maneuvers help define the source of AF. 1. Define the site of the shortest A wave cycle length, CL, that is, the fastest firing rate, for example, comparing the A wave CL in coronary sinus, direct left atrial recording, pulmonary vein channels, and high right atrial channel. 2. Mapping of activation sequence in pulmonary vein and LA channels. Atrioventricular conduction during AF. Ventricular response is irregular. Ventricular rate depends on the rate of atrial inputs to the AV node, the AVN itself, its properties, effect of autonomic tone, and effect of medications, and pre-excitation of AF, if a bypass tract is present. Usual range of ventricular rate in untreated patients, 90 to 170 per minute. Ventricular rates slower than 60 per minute are seen with AV node depression by disease, drugs, or high vagal tone. Faster ventricular rates are seen with sympathetic activation, for example, with exercise. Parasympathetic withdrawal. Thyrotoxicosis. Pre-excitation, in which case, the ventricular rate may be faster than 300 per minute. Concealed AVN conduction. The irregularity of ventricular response during AF is likely due to constant random irregular bombardment of AV node, which creates varying degrees of concealed conduction, caused by atrial impulses that enter the AV node into variable depths, but do not conduct to the ventricles, leaving refractoriness, that is encountered by subsequent impulses. Circadian variation. Circadian variation in ventricular rate during AF may occur, secondary to a circadian rhythm for AV node refractoriness and autonomic function. Pre-excitation during AF. Grossly irregular, very rapid, faster than 250 per minute, ventricular response during AF, is virtually diagnostic of conduction over a bypass tract, with rare exceptions. Pre-excited AF. In patients with manifest pre-excitation during sinus rhythm who develop AF. If the bypass tract refractory period is longer than the AV node refractory period, anterograde AV conduction during AF proceeds in the AV node, pre-excitation disappears, and narrow QRS complexes are recorded. When the bypass tract refractory period is shorter, pre-excited AF with wide QRS complexes occur. Multiple bypass tracts are suggested by multiple wide QRS morphologies. Bypass tracts are classified into high-risk bypass tracts, which can conduct very fast supraventricular rates to the ventricles, defined by a mean ventricular cycle length during AF shorter than 250 millisecond, and or the shortest ventricular cycle length shorter than 220 millisecond. Low-risk bypass tracts, which cannot do so, defined by a mean ventricular cycle length during AF of 250 millisecond or greater, and or the shortest ventricular cycle length is 220 millisecond or greater. Pre-excited AF versus ventricular tachycardia, VT. With very rapid ventricular rates, there is usually a tendency toward regularization of cycle lengths, thus distinguishing pre-excited AF from VT can be difficult. With stable hemodynamics, pre-excited AF is the most likely diagnosis, while rapid irregular VT usually quickly degenerates into ventricular fibrillation, with hemodynamic deterioration. Bypass tract conduction. Bypass tract conduction during AF is influenced by 1. Electrophysiological characteristics of the bypass tract itself, its refractory period, conductivity, concealed conduction, etc. 2. Spatial and temporal characteristics of atrial wave fronts during AF. 3. Autonomic tone. AF degenerating into VF. Very rapid AV conduction during AF would result in extremely rapid ventricular rates, possibly faster than 300 per minute, which may degenerate into ventricular fibrillation, VF. This can occur in the presence of a bypass tract with very short refractory period, especially when associated with AV node conduction block, for example, with drugs. Regular ventricular rate during AF may occur in 1. Complete heart block, with ventricular activation by an escape junctional rhythm. An escape junctional rhythm, with Wenckebach exit block, which will show group beating, that is, regular irregularity, due to pauses. Or an escape idioventricular rhythm. 2. Simultaneous AF and ventricular tachycardia, which will show regular wide complex tachycardia. QRS complexes during AF. The QRS complexes during AF are narrow, unless AV conduction is abnormal, because of pre-existing bundle branch block, functional, rate-dependent, aberration, or pre-excitation. Differentiation between aberration and ventricular ectopy is discussed earlier. Aberrancy caused by Ashman's phenomenon is defined as aberrant conduction of the beats following shorter cycle lengths during AF, because one bundle branch is still refractory at the time of arrival of the AF impulse. This may be present for one beat, resembling a ventricular impulse, or may involve several sequential complexes, suggesting paroxysmal ventricular tachycardia. The QRS complex during AF is similar to that recorded during sinus rhythm in the same patient, except in the following situations. 1. Functional bundle branch block or aberrancy, with wide QRS, during AF. 2. Conduction during AF in the AVN, with narrow QRS and loss of delta waves, in patients with WPW syndrome. 3. Totally pre-excited QRS complexes during AF, with wider QRS and larger delta waves, in patients with WPW syndrome. Thank you.